So I will speak tomorrow about the 6 trials that have been published recently and that have changed our life. For me, it's like for everybody a revolution, even more than the revolution of ISAT, the study for ruptured aneurysm 12 years ago. It is a second revolution in my practice of interventional neuroradiologist. It has completely changed the way we deal with stroke today. I was part of the writing committee in Europe and France to write guidelines about thrombectomy and the indication of thrombectomy. And so we have written that today the treatment of choice for every stroke in the first 6 hours is thrombectomy. So it has changed a lot. It's fantastic for us. I was afraid that we were doing well and we were not able to prove that what we are doing is really very good and very beneficial for our patients. So it is a revolution. We have a lot of information. We don't have all of them yet. They will be published in the next months. But at least what we know today is that the thrombectomy is recommended in every stroke in the first 6 hours in the anterior circulation as soon as you have a large vessel occlusion. We don't know exactly what are the indications of the thrombectomy, and for example if we should do thrombectomy in patients with very mild stroke, NIH 2, 3, 4, 5, or on the contrary, should we do thrombectomy in patients with very, very large stroke, very high NIH stroke, very high aspect score stroke, meaning very large volume infarction. So that we don't know at all. As well, we don't know exactly until when we can do the thrombectomy and what is the time limit. So we are saying it's in the first 6 hours, but we don't know exactly what it does mean, because it could be going to the angio at 6 hours, or doing the groin puncture at 6 hours, or doing the reperfusion at 6 hours. So that is, it's not clear in the guidelines. We were not able to precisely indicate what is the time limit. So there are still a lot of doubt, hesitation. We don't know exactly, but we know that we should do stroke thrombectomy in most of the cases, and probably, in my opinion, even in very mild stroke or very, very severe stroke. The technique works so well that even in this extreme situation of very mild NIH 2, 3 stroke or very, very severe stroke, maybe there is an indication to do a thrombectomy. So this is what we need to work on. Patient selection concerning the symptom severity, concerning the stroke volume on imaging. We don't know which imaging is the best. We do MR for every case. But as soon as we still have time, so let's say in the mothership patient, the patient who come in the hospital directly, then we do very sophisticated images. And when patients are coming from another centers, 100 kilometers from my center in Toulouse, they very often arrive late, at 5.5 hours or 6, and then we don't know, and then we don't have time to repeat the imaging. How to handle the need for such a treatment in very wide area. For example, I'm working in the region of France where we do take care of 3 million inhabitants, and some of the cities working with us and the stroke units are more than 150 kilometers from Toulouse. So then there are a lot of questions. For example, whether the patient should make a stop in a stroke unit to have a CT scan, to have an IV thrombolysis, then the patient is shipped to the main hospital, or should the patient be directly shipped to the main hospital to have the thrombectomy as soon as possible? So this is things that we don't know yet. It's a matter of organization, of transport, helicopters, and local decision. In some centers that are close to us, maybe it's good to have a stop, do a CT, select the patient, do the IV, then ship the patient. If the patient is too far away, maybe if he's in a very high clinical grade, maybe it's good to ship the patient directly to the main hospital. Then the other point, and I'm a bit afraid of that, there are people considering that thrombectomy works so well that, you know, thrombectomy should be done everywhere, in every country, in every city, even in a small hospital. My first point is, since 6 months we have had those 6 studies. The caseload in my department, they do increase quite a lot. We have done 80 cases last year. We'll do probably 160 or something like that this year, maybe 200 next year. But you know, we are not overwhelmed. We can manage it quite easily. We could do 300 or 400 cases a year. So people should not consider that because it works very well, it should be done in every small city where people are not trained. To do such a treatment, you need very important experience, because it's difficult to do. When you go in arteries of patients who are often more than 70 years old, sometimes more than 80, catheterization is difficult. You are catheterizing an artery that you don't see, so you need experience and knowledge. And if everybody starts doing that with no experience, you know, the result will not be good. And the other problem is that to do that, you have to offer a 24/7 service, meaning that you need 4 interventional neuroradiologists, 4 nurses, 4 technicians to do cases in the middle of the night. So to do that, it's a very important cost, and you can do that only in big centers. So the caseload will increase progressively, but it will not be a jump, a massive change in the amount of patients we'll do. No, I think that it's very important to keep this neurovascular pathway. I mean, we are dealing with an organ that neurologists, neurosurgeons, neuroanesthesiologists and neuroradiologists really know, and we just work on it since years. If then, you know, the patient is seen by an emergent physician at the hospital and then sent to a cardiologist, you know, you lose the real understanding of the pathology, ability to, you know, understand the images. So it's really a neurovascular business. So it should be done by vascular neurologists and interventional neuroradiologists. We don't do carotid coronary stenting. To do coronary stenting, you have guidelines about the amount of cases you must do every year to be allowed to work the year after, because you need to have enough experience and to keep your level of expertise. And then if, you know, people start doing this when they have no experience at all, it will be a disaster. Today, for example, in my lab we are 4. In 2 years we'll be 6. So we are more or less in charge of all the hemorrhagic pathologies, and now we are in charge as well of all the ischemic pathologies. So it's very good for us, for our field, and then it's good because we can, you know, train more physicians because we have much bigger field and amount of patients.